Esteemed colleagues, we're going to start the second half of our second day of the workshop related to issues of treatment of hepatobiliary area. I'd like to give a floor to V.Ratnikov, the Deputy Head Physician on Medicine Professor of St. Petersburg State University, Doctor of Medicine, Professor. He will tell you about a medical algorithm of fluoroscopy and imaging of the biliary tract pathologies. Of course, after the lunch, we don't have that many people as before. It's hard to get the information, so I'll try to pay more attention to the video. And of course, I don't want to discuss the importance of the topic because the lectures you already heard yesterday and today, and the condition of performance of the patient you saw during the translation makes possible for me to say that imaging technique and modalities used in that format, they provide quite considerable set of information to us, and which make possible to properly select treatment strategies and imaging modalities. They first of all should, after we assume the type of the pathology, they should provide and after we assess hepatobiliary system, and we should, as most objective as possible, to assess found pathological fluorography signs. It will help us to do differential diagnosis, to find out if the disease is operable or resectable, and at the end of the day, it will establish optimal patient management, which will finally result in shorter diagnostic time, improve functional quality of the method, avoid side effects, and limit or exclude radiation or excessive radiation. Think about that. In about 2 weeks in Chicago, there going to be the 100th Congress of the X-ray Society of the Northern America. So our colleagues have met already 100 times. So we remember that the day of the 8th of November, it just passed 115 days since those technologies, since those imaging techniques have been implemented in the diagnostic process. To visualize hepatobiliary system, we might use different principles. They're all quite clear. I don't want to discuss them more or additional. Of course, we are more interested in those modalities being presented in the lecture. The ones you saw during the demonstrations, it's ultrasound, endoscopy, and of course conventional X-rays, and of course CT and MRI. We know the resolution, which could be applied, or which could be obtained with ultrasound. When we talk about the biliary pathology, gallbladder pathology, that's easiest, the most informative message, which gives you 90–95% of answers. Of course, conventional fluorography, they existed and they will exist. No matter what we tell about them, no matter how negative they might be, but still we think, what we're saying, but they will be used for a long time. And concerning the biliary system, we see the strong progress of the method of computer tomography. And you saw it in lectures, and you know that ERCP has lots of positive sides. It's a high resolution. You can easily diagnose those filling defects, and And as Professor Larger said, the most important, this method makes possible to combine diagnostic and therapeutic interventions. CT scan. You see, as to the quality, it's not the latest tomographer device, tomograph machine, but it makes possible for you to see gallbladder, liver, pancreas, to see contrasting stones. So this method could be used, and it really provides you with considerable information. But we are interested, of course, in functional methods, like scintigraphy methods, which dynamically and functionally shows you diffuse or focal changes in liver and biliary system. Of course, it's very interesting to use fusion technologies, where we combine two images from different methods. Like in this case, we can see that we use a SPECT, which is actually the isotope diagnostic methods, and CT. When they're combined into CT SPECT method, you can say that it's not. We can say that it's not only. We can say that it's not only says that it's a seventh liver segment, but we can clearly see that it's a liver metastasis. But it's very important. But nevertheless, if we talk about the examination methods and imaging modalities, you can know that they have their advantages and disadvantages. And MRI is a very specific technique which per se has a range of advantages, and there are some, and it has not that many of contraindications. So most of them are relative, so to say. And you will agree with me, I suppose, that to tell the patient that you should go for MRI for liver and hepatobiliary system is not enough, because you know that MRI today implies the whole range of methodical techniques, which gives you native T1, T2 weighted images, then non-contrast and contrast in MRI, contrast MRCP, dynamic contrast enhancement, and MRI diffusion or perfusion. These methods are really rapidly methods which are rapidly developed. It's MR spectroscopy and MR elastography. Then T1, T2 weighted images are very important. In one image you can assess the structure. You can see these are lesions like ascites, cirrhosis, anastomosis development. We can diagnose not just gallbladder stone, but you can assess them from chemical point of view. It's a stone which cholesterol crystals are in a core, and it grows from inside to outside. But surgeons will say, why should you do MRI in case of acute cholecystitis when everything is clear? But nevertheless, you see such a considerable peri-process. During the study, we see anatomy data, which actually can considerably alleviate or considerably amend the surgical management. And MRCP, this method, which quite clearly shows you signs of biliary hypertension easily, and could even tell you about the causes of this hypertension. And even cholangiography has a different tricks with different, so to say, advantages. It is a thick section, thin section, 3D reconstruction with MAP algorithm. And also we can use dynamic studies of biliary tracts using hepatospecific agent Primavist. You can see sections showing ZZ organs. Here you see the duct. You see the you can get paraductal cyst with a size of 2 millimeters. It's just It's a fantastic. Depending on the method, you can see better confluence. You can see CBD using scene section method. Depending on the section size, we can visualize a section. We can visualize CBD, and like in the anatomy, you can see the spin-like structure of the bladder duct. But biliary hypertension lesson could be started here, because the reason of the biliary hypertension here is CBD stricture. You can see clear-cut hypertension, and look at the gallbladder. It goes down almost to the small pelvis. Which method could so clearly or as clearly obtain image of the patient? None, except for MRI or MR cholangiography. That's another example. It's a patient post-cholecystomy. You see the stone impacting into the CBD. That's another method. It's a dynamic method. T1 MR cholangiography, dynamic, which helps you to visualize how the agent, how the therapeutic agent is secreted with bile. MRCP method is very simple. Depending on the contrast drug, we could say gadavist, and up to other drugs. You can obtain necessary information. You can, depending on the phase, you can see arteries in the abdomen. You can see the vena porta. We can do vena portography, or you can use this method for some other purposes, especially if you plan some surgical manipulations in this field. And of course, we cannot avoid but to say that quite often the search for necessary contrast between the structures makes us to think about the drugs to be the most optimal, meaning which could objectively show the these or that changes. Look at the list of drugs we have, or agents we have outside Russia. Here you see only these drugs, non-specific extracellular gadolinium chelates. It's not iodine drugs, it's gadolinium drugs. Then we could use Primavist, but other drugs are not available for us. And we're really envious to our colleagues who could use various agents. And I would like to say that the use of contrasting agents, we need it at this stage, at this very stage, when we at the preclinical or subclinical stage to see these or that changes. Because if there is a destruction, if there is a clear clinical pattern seen, the use of contrasting agents is not of that much help. A very interesting case. A T1-weighted image of this. This focus looks not quite nicely, but the specialist could immediately say that there is a sign of a benign disease, and the contrast accumulation type clearly indicates that that's a benign structure called hemangioma. None of the diagnostic methods, none of the manipulations are necessary. It's a classic picture, classic accumulation, and clear diagnosis. Unlike this case, which looks considerably less nicely, there is a sign of destruction, goes outside the capsule, and it's a malignant tumor, which is called hepatocellular cancer. It's important not just to explain it quantitatively, but also we should analyze various quantitative indices, I mean time-wise changes. And with the biliary system, panoramic scanning will not provide you, panoramic scanning with ultrasound will not provide you with such panoramic view. But you know that such a gallbladder should produce symptoms, even more severe as in the case of colic. That's in this image we could obtain in 4 seconds. We could see all parts of the biliary system, and also assess its architecture, because if you would like to cannulate major major papilla, you will not obtain and cannulate the CBD. You cannot do it at the same time, and it's very important because you can do it. You can analyze it during MRI. At this image, you can see there is some expansion. There is some filling defect of in the CBD. But if you do the study methodically properly, here we can see the biliary tract variant with a long gallbladder duct, which is in confluence with CBD intrahepatically at the left. If you do cholecystectomy and you leave the long stump, I can agree with Viktor Anatolievich, it will provide any clinical signs. It is a predictor for development of residual CBD stones. Another disease, non-visualization method will show you the gallbladder this way, as you can see with MRI, where you can see this porcelain gallbladder. Ultrasonography will not give you a clear picture. CT scan also will be kind of a blurred. But we're interested not in the search of concrements of stones, because you can palpate them, but we're interested in diagnosis of really small inclusions in the biliary system, or differential diagnosis of so-called sludge, which also produces some clinical signs. And at this presentation, I would like to mention that if we look at this image obtained through 3D processing, we cannot clearly say which is the reason of such a considerable biliary hypertension. But looking at this image of in the thick section, we can see classic menisc symptom, which never happens with tumors, and it clearly tells you about stones being present. Another symptom, it's a stone being impacted into the distal part of the CBD and in the large papilla, and you can see expanded stump of the duct. So it's one of the signs of biliary hypertension. Of course, it's very important to find such inclusion into the CBD, and it knows that different sources says that up to 70% of stones in the CBD are found in case with non-expanded CBD, and if you cannot visualize retrodental part of the CBD, you can say there is no problem, it's not dilated, but there is a problem. And if you look at the endoscopic ultrasound, EUS would be sufficient, and the use, and in these cases, therapeutic doses of UDCA could quite, in a short time, in 1-2 weeks, could produce very good clinical results in such patients. Then post-surgery settings, it's not always it goes like we we hope, and MRI is very effective method. We could assess the drainage status. You can look at the cystic duct. The cystic duct stump is very long, and MRI is a method of choice in assessing iatrogenic lesions in biliary system if the anatomy was not appropriately ordered. Here we can do RCP, we can do fistulography to see intrahepatic ducts, a combination of RCP plus fistulography. You see how much of patients rentgenologist and patients should have. But the amount of information for 4-second MRI or for 18-second breast holding with MRCP, it gives us a whole picture, because you could see that the CBD was damaged in several places, which we couldn't see with conventional X-rays. Then aged patients, or with development of some inflammatory changes, patient might develop strictures. Clinically, it's very important to diagnose it on time and to introduce necessary treatments like UDCA. And the use of this method makes possible later on to plan diagnostic through EOS and through therapeutic through stenting management. Before MRI, prior to MRI, HCP was considered to be the most informative, but here you see classic symptoms of bead-like expansion of extrahepatic ducts and local, so to say, local lakes in the intrahepatic ducts. You can have this information with MRI, but look about the radiation, about the labor, so to say, consumed for X-rays. In the first talk, which was said in the morning, there's a patient which we saw yesterday. Is this person at the back feels okay? He's like he like opened his mouth, and the first talk was that the patient in this master class, the elevated MLAs didn't produce any result, any changes. The patient has some manipulation-related complications. That's a classical case where the anatomy was not assessed appropriately. We could see additional Santorini duct. Then we see CBD main duct. We don't see biliary tract, so patient has a jaundice. We do MRI. We see expanded or dilated CBD and signs of slides of secondary biliary hypertension, sludge phenomenon. The patient underwent papilla sphincterotomy. Jaundice was resolved. And further on follow-up, when they did control their HCP, you could see that proper cannula placement make possible to visualize bile ducts. Hepatobiliary system messes. Of course, we shouldn't forget about it because it's a very important pathology, and quite often. And the picture shown by our colleagues from Singapore, this is pictures in a kind childish style, but it clearly shows you how much of information you should provide for the surgeons. We should not only determine the cause and location of the lesion, but also how this neoplasm, how this mass affects both biliary ducts and parenchyma of adjacent organs. And of course, we shouldn't forget about the gallbladder cancer. It's kind of not very rare. It's 6% of all disorders of GI tumors. It has a very clear clinical signs, and it's easily to suspect it when doing ultrasound. But still, there could be some questions. If the tumor is spread to the adjacent tissues, what is the relation to the bile ducts? And MRI provides with lots of information. Then hepatocellular carcinoma. We can see the primary node. We see intra-organ spread and metastasis. The tumor grows, and in the center you see the tumor destruction, very typical syndrome. And you should find a clear answer. If one lobe is involved, how much of the liver is involved? This condition, which results in hospital admission, patients are different, but the pictures are quite the same. Only when the lobe bile ducts are blocked, patient come to the clinic, but it's hard to help them in this condition. But we should understand that depending on which duct is invaded mostly, we can say which of the tumor we have, and stage it by TNM, using the TNM system. Very interesting case, very clear symptoms of Klatskin tumor in both T2 weighted images and as well as with cholangiography. And PAD showed hyperfixation here and elevated activity of fluorodesoxy of FDG, which confirms the tumor presence. But the use of PET in patients with presence of a suspicion of biliary mass makes possible to see metastasis in organs which are not a zone of interest with other methods like the left lung and left coccygeal iliac joint. Here you see what kind of specimen we have. It's a primary CBD tumor, and you see high activity of FDG. And the morphological substrate, and we saw such patients with Evgeny Solnitsyn, who had such patients. In some cases, PET is silent. Patient comes saying, how come? One doctor told me, another doctor told me, the third doctor recommended PET, but there is no mass. But regretfully, not all biliary tract tumors produce positive PET. When we studied with FDG, we should understand that the primary or driving diagnostic driver here is a clinical science, and no PET should not be the management, should not be the reason to change the patient management. That's our patient, our colleague, the nurse. We diagnosed that she has some problem in the confluence area. We confirmed Klatskin tumor. A patient underwent surgery. The tumor was resisted. Patient underwent surgery, and the patient is alive already 8 years. And it's important because here the surgery is done with appropriate approach. And here, unlike previous patients, it results in stenosis. And stenosis could result in such considerable changes in liver. This patient underwent surgery and treatment in Israel. Then he came back to us. Regretfully, he died. We couldn't find him. We couldn't help him because there was sepsis and multi-organ failure. And Primavist, I already mentioned it. That's the agent which in a unique way improves method functionality, and due to that, and because it's very simple and easy, I mentioned it yesterday, you could neutralize those negative sides. Not everybody can see what is here and there, while forms are well, there are much more forms. You can see it better and here, and now you can see who and what is doing here. So all the same could be done if we use contrasting agents properly. We could have the same result. Contrasting agents, they improve parenchymal signal, and they make possible to better see non-contrast accumulating areas. Of course, we should use special estimating system, not to be based on visual assessment. And for that, we should follow very strict study protocols. We should find the zone of interest, and this zone of interest should undergo quantitative analysis. And here you see the series of patients, classical hemangioma patients, how nicely it looks when Primavist is used in hepatospecific phase. You can see different drug accumulation rate. Another patient with primary liver cancer, he was embolized. There was a big issue, is there a continuous growth or not? There is a continuous growth because the part of this tumor, it was a highly differentiated tumor. It's accumulated contrast, which was shown by quantitative parameters, and we found out that the treatment result was only partial. Then colon carcinoid metastasis without Primavist, we will see this pattern. But if we use hepatospecific contrast, we can visualize secondary changes with a size up to 3 millimeters. Would you would ask me if it is important? I told you yesterday. Here we see the very bright head of our oncology unit. It's very important for him to know how the drug works, and the search and presence of small forms prior to treatment, and analysis of how those secondary structures regress because of treatment shows if the treatment is effective, actually. And the drug is very effective when we try to assess iatrogenic damages. Here you see in our clinic, Primavist use clearly shows that we have damaged bile duct. Primavist is safe. There are no specific complications with Primavist. It improves effectiveness of our diagnostic process. At the end, I shouldn't but mention, I cannot but mention the tomorrow. So we'll see in the future. Of course, it's a diffuse weighted protocols, which without the use of any contrast, without the intravenous administration of gadolinium, it makes possible to see secondary focal lesions and differentiate them. It's actually to impress you, because color is used just to impress others, to make brighter articles, and but for colorectal cancer metastasis diagnosis, we should do quite labor-consuming examination, which with DVI could be done quite easily. We could use DVI to assess some therapeutic manipulations. There is no effect because volume of the structure intensity on the diffusion biopsy didn't change. And see here with the treatment, the tumor decreased in size in a short time after ablation. Then MR elastography, it's of applied value, but even you, not specialists in that area, you can say that this image without fibrosis is considerably different from that one. So it means that this method is quite promising, and it's saying that in the future, in our days, so to say, when we are still in practice, we will see more useful, so to say, results. Ultrasonography. Well, regretfully, in congresses with sections on reports on presentation on CT and MRI, they do not talk about ultrasound. The scientific factors, they, so to say, they diverge. Some and people think that they have different, so to say, the vectors. But it's great that in our clinic we think about combining those methods, and you can see that through analysis of acoustic structure, we can nicely assess, quantitatively assess tissue structure. It's not just labor-consuming, and also we use elastography, which makes possible even in treated patients to say which kind of an effect we hope to reach or we will reach. Of course, today we should mention about the use of son of you. I mean the ultrasound with contrasting. It's so great. We work with the companies promoting it, and this one, due to the presence of the gas bubbles, it makes possible to be, so to say, very effective in diagnosing origin of lesions in the liver. Of course, in this audience, of course, we should mention the EUS. You saw it yesterday and today. Look at the resolution of intra-CBD structure. You see normal wall, and you could see almost a complete occlusion here. You see larger size image, and you could see how unique this method is, especially in situations where the results are quite dubious when doing MRI. Of course, MRI has lots of advantages, but we should say that my point of view is that basic method for differential diagnosis of pancreas is a CT scan. Then MR studies is a golden standard for disease, is a golden standard for diagnosis of biliary and liver disorders. for the gallbladder, ultrasound is quite sufficient. And it was very nice to talk to you, and thank you for your attention. Thanks a lot, Vyacheslav, for a great lecture. Esteemed colleagues, are there any questions to our speaker? Vyacheslav? I would like to ask you, if we compare ERCP and MRCP, we're talking about the diagnostic value of those methods. Could we say these methods are exactly the same, or HCP could give you more of a diagnostic value? Yes, it can. Like diagnostic method could be. I cannot be as clear-cut as yesterday, but it can give you some diagnostic advantages. Please take the microphone. First of all, I would like to tell you about yesterday and today's talk. I'd like to thank you for, as a therapist, I'm ready to be useful for you. And it looks like you promised another lecture to us. But a question about the visualization with Primavist. As I heard yesterday, we can use it to diagnose the sphincter spasm. We use it, biliary scintigraphy, as a cheaper dynamic one, as a cheaper method. But the question is, because it's on classification on grades, is an MRI classification because of the grades, because of different management as a therapist or surgeon? Are there classifications or not? They do exist. They developed. But they are developed at the level of a PhD thesis. But there is no, like for CP, there is no such a generally approved classification. They usually ask about the cost of this drug, of this agent. The cost is 8,000 rubles. It's these days it's about 150 euro. And so if you assess the cost of one cycle of chemotherapy, it could be 500 to 600 euros. It depends on if the patient or if the clinic is lucky, and it has been proven. But the cost of the drug, from the point of view of sparing the money, it gives you lots of information prior to planning surgery or chemotherapy. So it's very good cost-benefit ratio. And you said also there is a classic science of hemangiomas, and if you do with some issues with hemangioma, you study with labeled erythrocyte. With current technology, you can avoid it. Yes, sure. There are atypical forms, and they have been described, producing a little bit blurred imaging pattern. But if the contrast is accumulated in delayed phase, when it's accumulated from periphery to the center, slowly filling the structure in a kind of a foam-like pattern. One of the cases was a giant hemangioma. I didn't believe my own eyes, because my knowledge could change the patient management, and she did it. But it's not a classic feeling of hemangioma, but still hemangioma has been proven, has been confirmed. In some cases, not to give false negative results, you could use labeled erythrocytes, but in classical cases, you don't need it you don't need it at all. Vyacheslav, I'd like to ask you, what of differential diagnostic science on MR cholangiography between benign structures and cholangiocarcinomas, because strictures, because in both cases we see narrowing. It's a very good answer. The most typical science, you can take a seat. Yes, sure. The strictures, they usually has a cone-like structure. Usually there's a symmetric or asymmetric on one side, and the walls, the CBD walls and the stricture walls, the thickness of the walls at the stricture level is similar to the wall thickness along the whole CBD. there is no stump symptom at all, you don't see it. And with regard to the dynamic follow-up, if you're involved in imaging diagnostic processes, if you treat this patient, if you have some doubts, you should repeat the control study. And at the control, we don't see quite considerable changes. I mean, the strictures which become clinically relevant, it takes quite lots of time for them to develop. And if you want to have an answer today or tomorrow, and to avoid time-consuming follow-up, and if you have any doubts, just refer patients to AUS because it has such a high resolution that you can get this answer at once, almost at once. If it is a stricture, if it is benign or malignant. Okay, esteemed colleagues, more questions? Yeah, thank you. Thank you for your attention. We know each other, Victor. We see we have. So you have interesting patients. If you have any questions, you can ask to us. We know each other with Victor, and we talk to each other quite often. So we always would be happy to help you. Thank you.